Hello, we're back. It's the hashtag See Arthritis event here at the 2018 Canadian Rheumatology Association and Allied Health Professions Association annual meeting. And it gives me not only great professional pleasure, but also great personal pleasure to invite Dr. Deborah Marshall to our broadcast booth. She's been someone that we have worked with in ACE over the years. We have, I think, grown to appreciate what we each do in our professional worlds, and probably me more so than Deborah, because Deborah's a really important lady, and I'm going to take 2 seconds to tell you who she is. Deborah is the Canada Research Chair, Health Services and Systems Research. So that means in the highest land, she's been appointed chair of those fields, which is a great honor. So congratulations again. I know you've held the chair for a while, but still worth congratulating. She's the Arthur Child Chair of Rheumatology Outcomes and Research, and very importantly, a professor in the Department of Community Health Sciences. And she's saying, don't read anymore. Okay, so all of that to say, welcome. We're so happy and proud to have you here with us. And we want to talk to you today about some of the things that are on your mind, some of the things that you talked about here at the meeting. But first, something very, very simple. Describe to us in short order what you do.
Well,
there.
Okay.
How's that for an opener?
The opener.
Yeah.
Well, my research, first of all, I'm a researcher,
Yeah.
so I'm a health services researcher and a health economist in a broad context. But more specifically, the areas that I research really are around what they're called patient preferences.
Right.
So understanding what matters to patients and trying to measure that in a quantitative and robust way. And then secondly, doing simulation modeling. So, gathering pieces of information together and trying to interpret them in a cohesive way and also predict the consequences of patterns in the data.
Yeah, so I know our Facebook and Twitter live audience's ears perked up when they heard patient preferences.
Okay.
Because, of course, we all prefer things, and we
Yes.
hope that they're actually out there and on offer for us to choose from, which is, I think, an important piece that maybe gets lost sometimes in the healthcare system, not necessarily in the research work that you do. So in thinking about the patient preferences work that you do, the stuff that you presented at today's meeting, for our audience, tell us what the take-home messages were.
Yeah. So patient preferences, first of all, I should just explain maybe what I mean when I say that.
I know, and that's why I raised
Yes.
it, because when we consumers hear patient preferences, we think something, and it may not be aligned with what researchers think it is.
Yes.
Yeah.
And so when I use that terminology
Yeah.
in my research, I mean very specifically, not just looking at information that says, I like red versus blue.
Right.
Now that's a type of preference.
Yeah.
It is a preference.
Yeah.
But when we are thinking about this in a technical kind of context, we're asking people about their relative desirability and acceptability of interventions or treatments or
Right.
anything really,
Right.
in a context where it's being presented as trades, so you have to make choices amongst things. And what that does is give us a robust, utility-based measure of preferences. Because it's easy to say, that's really important to me.
Yeah.
But when you have to say, having an effective treatment is really important to me, but if there's a counterbalancing thing called side effects,
Right.
then now you have to say, well, which thing is more important to me and how much?
Right.
And when I ask it in the context of the relative desirability,
Yep.
I now have a utility-based preference for something.
It's a complicated and fascinating way of getting to the chase, but there's a science around it, is the bottom line.
Yeah,
And
that's a good summary. Yeah.
It is, yeah. When you think about how patient preferences and the science behind patient preferences relates to the theme of this meeting,
Yes.
how do those dovetail?
Yeah.
Lay it on
to me,
us.
perfectly.
Yeah.
And that's why I was excited in particular, I guess, this year because of the theme, which is personalized and precision medicine. They've put them both in. But for me, I think this is a way of trying to highlight the idea of patient-centered care. And I know there's lots of debates about what patient-centered care is. But to me, preferences methods are a vehicle to try and capture that in a more explicit way.
Right.
Like we, of course, people have preferences, and yes, things matter. Some things matter more to some people than others.
Yeah.
But how do we capture that? How do we include that in some of our decision-making processes? So when I interact, as I do in my research very commonly with clinicians who deal with patients every day, often the response will be, well, of course I know my patient preferences because I talk to my patients when I'm, trying to think about prescribing. But I think we can improve, I guess, essentially that communication and that understanding, because arthritis is a preference-sensitive condition, right?
Okay, explain that. What do you mean by that?
It means that treatments have benefits and harms. They have risks and harms that we need to balance against one another. So when people have to think about choices in treatment, they have to weigh those benefits and the risks.
Right.
And the other little fact in here that's really important, and all of you will know this, people don't adhere to their treatment very well. So when we think about how do we manage patients and how do we treat patients in the best possible way for that particular patient, not based on what the randomized control trial
We're talking about
tells
precision,
us.
so individual patients.
Individual patients. I can then say, well, Cheryl, is it more important to you that you have the most effective treatment, even if you have going to have more side effects, but they're mild side effects?
Right.
I can begin to understand what matters to you and what's going to increase the likelihood that you will adhere to that therapy because it's working for you.
Yeah.
And then ultimately, if you adhere to the therapy, then you have the best outcome.
So that actually makes sense to me.
Oh, good.
And what makes sense to me from a patient perspective, which I am, as you know, is the realm of choice. And when we're talking about treatments and choices, we're talking beyond pills, right? It's any kind of treatment, pharmacological or non-pharmacological.
Yes.
It's complicated.
Yeah.
Like there are, in the autoimmune arthritis space, there's so many different therapy choices, and the way you escalate those choices and when you escalate those choices and for the reasons, it's complicated. So what what I'm hearing from you is your science will help us in that process.
Well, I think so.
Yeah.
I really do believe that. And I will also say that it's been really interesting as a researcher because we work really closely with a large range of kinds of patients.
Right.
So you are constantly learning as well.
Yeah.
But I see 3 different areas where we can use patient preferences, I think, very directly and in a very relevant way.
Okay.
One is in the context of clinical practice. Can we specifically elicit and understand what that individual patient, what matters to them most, that we can tailor that treatment approach for that individual?
And that it happens within that clinical setting,
Yes.
like in the office with your doctor.
Yes.
Okay.
Secondly, in the formulation of clinical practice guidelines, one of the things that's been going on recently is thinking about the development and evaluation, and also the development of guidelines, development of recommendations from the guidelines, and how we move forward with that to embed patient preferences used loosely. But now I think we need to think about how can we do that explicitly and in a way that can incorporate it into that whole process. And one of the things that we do know is that it's quite common that patient or provider, healthcare provider preferences differ from patient preferences. You're smiling because I know.
Because I know. I mean, most
that.
patients know that. Yeah.
They do, but
Yeah.
there's actually been a systematic review done recently. We've done a few of these comparisons as well.
Yeah.
And it's not surprising.
Yeah.
But sometimes you need the data to show
prove it.
and
Yeah.
prove the
Yeah.
differences. So we've actually seen this, and what's interesting, I think, is that if you think about structure, process, and outcomes, you know, using that framework in terms of interventions and how you describe them, physicians actually tend to wait and think that the structure and outcomes are going to be most important, but actually patients actually wait to process more than the provider does. You're smiling again.
I know, because I find,
yes, of course.
You know me, I'm a science junkie. I think this stuff is so fascinating, and it's why you're here explaining it to our membership and to our Facebook and Twitter Live audience. It's a really amazing, and I don't think I think some patients in the public or public as patients, know that healthcare providers practice the art of medicine, for lack of a better way of putting it. And I think it is an art, especially in rheumatology, when we sometimes don't have hard and fast tests to guide their recommendations of treatment. It's these guidelines that do frame, in many ways, the way they approach not only groups of patients, but individual patients. But your science makes it a more precise conversation, I think.
And focused on that individual.
On that person, that's right, yeah.
So that's the second thing.
Yeah.
So one of the things you were talking about, you know, how this can be used, one of the things I'm very excited about is that we, fortunately, as a team, we're very happy to receive the Genome Canada Large-Scale Applied Research Grant. Plus
fantastic.
The Inflammatory Arthritis Research Grant. So this is the You Can Do network that was presented earlier here at this meeting today. And the PIs
This is
are
with Dr.
Ray
Susan
Young,
Bensler.
Susan Bensler and Ray Young.
Yeah.
And
who we interviewed yesterday.
Yes, I was going to say, I'm sure they're on your list.
Yeah.
So they'll be coming up next, so I won't say too much about that. But one of the pieces of that whole research, which, by the way, is focused on understanding childhood arthritis.
Right.
So the focus in this particular, these two grants are on juvenile idiopathic arthritis, which I really like, too, because so many people, and we've had this conversation so many times, but don't understand that arthritis isn't just an old person's disease.
I know.
So I'm really excited that we have an opportunity to do some nice research, I think, in juvenile arthritis. And two, we are going to be using mobile technologies like e-health technologies to embed patient preferences measures to think about how do we inform when and how we can start tapering treatment in these young individuals.
Which I'm sure both the children and the parents are thrilled about.
Yes.
Yeah. I think looking at precision medicine, personalized medicine, whatever buzzwords you want to put around it, in children is so important. And I was so thrilled to hear about the award of the grant to your group. I think it offers us, and also because it's a smaller group of people, is it wrong to think that the learning happens faster if you have a more concentrated population?
Well, I don't think so.
No.
I don't. I mean, I think actually one of the shocking pieces of information, which I did have to verify multiple times, is that every single pediatric rheumatology center in Canada is on this team.
Yeah.
So we essentially have all the centers. So one would hope, I think you're right, that we'll be able to accumulate these data in a standardized way such that we're going to be able to bring this information to bear in clinical practice quite quickly.
I was going to say, well, that's
learn.
in business that would be called fast tracking. And I think that's kind of, well, to the extent that you can fast track science, it is. Let's just go with it for now, okay? Listen, I want to talk to you about digital health and social media and what you think its role is in medical research, if any. I'm not trying to pass off that it should be or what, but
Yeah.
love your thoughts on that.
Well, to me, the exciting part of it is I think it offers other opportunities to gather data.
Yeah.
And so I think it's an opportunity and a good thing.
Yeah.
Because I think we're expanding our horizons beyond very traditional study designs in terms of collecting data.
Yeah.
And we know that that's important. The somewhat scary side of this from the science is how do you interpret and analyze all that information, and how do you make sense of it?
Yeah.
And I think that remains a challenge and an opportunity, I guess, as well. But I think that's the challenge that we have to be potentially cautious with until we understand how to interpret
it, how to apply. Yeah, it's really fascinating. I was fortunate to see a presentation last year, and it was a gentleman, a team actually, led by this particular person whose name escapes me, of course, at the moment, but it's called digital anthropology. Mm-hmm. And they did, I guess there is a growing science now in how you look at social media content, how you sort it, how you quantify it, and what you can learn from it. And it was really fascinating. And what I most clearly remember was that in this digital anthropology exercise, the N of one is really important.
Right.
It's the individual person's experience beyond a number of tender and swollen joints that matter a lot to people. I want to sort of close our session off with a question about Coask.
Okay. And I have one more point that I want to make
okay,
out
sorry.
to.
Sorry.
May I?
Yes, go.
Okay.
You're in charge of me.
Really?
Yes.
This is a first. Okay.
It'll be the last time, by the
Okay.
way. Okay.
Understood.
Okay.
Okay. But the third, I guess, aspect about patient preferences, and as a heads up, folks, is that there's a lot of regulatory movement about how do we use patient preferences.
Oh.
So the FDA, I would say, has been sort of taking the lead on that. But they have issued guidance a couple of years ago now saying that patient preference information, like we were talking about, will be and can be used in regulatory submissions. And this is a huge change in the landscape.
Yeah, we do a lot of these patient input processes and know how important that would be. Yeah.
Yes. And
wow.
So in Canada, that's also changed in the last short while, relatively speaking, from our national level, as you know, with the Canadian Agency for Drugs and Technologies in Health, where that's a component of the input. But what's different from an FDA perspective, and also the European Medicines Association as well, is that they're now explicitly thinking about it as part of the regulatory decision-making process and examining what are the valid types of studies that can go into that decision-making
I just love hearing this because from a regulatory or a policy-making perspective, it is an evidence-based way to bring the patient to the center. And I love that because so many of us who do that kind of work out in community feel like even though we're at the table, we're not heard. But if you have a scientific process that helps bring it forward, then you kind of feel like, okay, there's the rock solid proof of it. It's not just, one person who might be perceived to be biased or not saying something.
Yes, I think it makes it more balanced and on the level playing field of clinical evidence and economic evidence, and now we're going to
patient
evidence.
Love it.
So I knew you would. So
Love
I
it.
had to say that.
Thank you.
What was your last question?
Coask.
Yes.
I want to hear about Coask. So perhaps demystify the acronym.
Okay.
And give us your best 30-second elevator pitch on Coask.
Goodness.
Well, because it's an exciting project and it's related to osteoarthritis, which millions of people in Canada live with every day and wish they didn't have it. And I think it's going to be a super cool tool. So talk to us about that.
Okay, so this is a project that's funded through CIHR in a knowledge to action grant. And the intent of this tool and it is an app that's being developed, or has been developed, at least in its very infancy stage, to try and help patients with OA, and it's NEOA.
NEOA. Oh, that's the Coask.
Yeah.
OA.
KOA, and ask is ask. Right.
Yeah.
I didn't come up with the
I like
little
it.
acronym.
It's good.
So the idea of that is that can we help patients in self-managing their OA? So the tool has been developed both in conjunction with PACER, which is the Patient and Community Engagement Research Group in Alberta. And these are patients who are trained with some qualitative methods of inquiry to conduct research in other patients and gather that and bring it back. So we've co-designed it with the PACER group and also primary care physicians in the ENACT group. And we've used cognitive task analysis with the primary care physicians, and we have gone through a series of co-design sessions with patients and with physicians to develop this tool, which is meant to help trigger, when a patient should be thinking about having a discussion around
with their doctor,
OA, with their doctor, and how to engage in that conversation so that they can get feedback about how they should be managed.
So the when and how, which is really important in arthritis. It's when do I know I should have this conversation, and help with having it. Sounds like are some of the key ingredients of the app. When are we going to be able to download it?
Well, we do have a minimal viable product that's still being tweaked. So the current estimate, and I think I'm afraid to say this on public, but in the next month or so, we should be able to have something that could be shared. And so we'll be very happy to have people test it out.
We are so going to be there for you. We have a whole audience full of Facebook and Twitter people who will be happy to probably sign up and test if that's what you're looking for. So thank you so much, Dr. Marshall, for coming in and talking to us about your work. It's so fascinating. We could hold her captive here for another 4 hours and wouldn't even begin to scratch the surface of all the cool stuff that you're working on. Do we have any questions, Anita?
So how much is the pharmacy industry guiding the choices given by the doctors?
Ooh.
Gosh, I'm not sure I can answer that. I mean, that's a very, I think, specific question to physicians, and I think there would be probably a lot of variability to that, but each physician, practices according to what he thinks is best, so I really can't comment further.
Yeah, I guess that's how I would answer that question, frankly. And
I'm sounding like you.
No. And I would add, actually, we all are subject to direct-to-consumer advertising. Even though it's not allowed here in Canada, we have U.S. advertising spilling across our airwaves every day. And I like to think that, as we were talking about a few minutes ago, there are clinical practice guidelines. There are guidelines for physicians to follow. And in fact, in Canada, so many of the medicines that are prescribed to people, particularly with autoimmune types of disease like rheumatoid arthritis, ankylosing spondylitis, and so on and so forth, the government will only pay for certain things in sequential order of prescribing, from least expensive to most expensive. So the biggest pharmaceutical advertisers, actually, physicians can't prescribe those medicines first anyway, even if the advertising were to be fully effective. So I think it's a great question. We're not actually certain, but we know here in Canada there are guidelines, and there are
in many other countries.
And there are also restrictions with how you practice. So great question.
Thank you, Deborah and Cheryl. We have 2 more interviewees coming up, so we will have to end this.
Okay, wonderful. Thank you so much again, Dr. Marshall. It's been great.
Thank you. My pleasure.
All righty.